So thanks very much, everyone. For anyone who doesn't know me, I'm one of the Glenfield ICU consultants, and I do quite a lot of managing ARDS. And over the next probably 40 minutes or so, depending how much I witter during it, I'm going to go over some of the evidence-based management of acute respiratory distress syndrome. And this is something that we love as intensivists because it's only really us that looks after it. But unfortunately, it means that we lump all ARDS together. And actually, it's probably quite a different disease depending what caused it. So anyway, over the next sort of 40 minutes, we'll go over definitions, really important, define or die, what causes ARDS in our patient population, a little bit about the pathophysiology, which I think is quite important to understand when we're thinking about what we can do to manage these patients. And then we'll briefly go through the management principles and actually what is evidence-based and what isn't. And we'll sort of touch on lung protective ventilation, kind of a bit about the open lung approach. I'm going to talk about PEEP and recruitment manoeuvres, a bit about APRV, the Marmite of ventilatory modes. You either love it or you hate it. Bit about fluid management, bit about paralysis, bit about steroids. Can't remember if I've actually put that in there because I can't see it. And then, oh yes. And then all the stuff that actually doesn't work that we've tried in the past. So, I might moving forward. There we go. So what is it? So define or die. So here's probably quite a good definition that you could trot out in an exam. So it's a spectrum of lung diseases characterised by a severe inflammatory process causing diffuse alveolar damage, or DAD, resulting in variable degree of VQ mismatch, severe hypoxemia and poor lung compliance. That is a bit of a mouthful. And actually, when I'm talking to the med students about ARDS, I describe it as the lung bit of the systemic inflammatory response syndrome. So I think that's an easier way of sort of thinking about it. And it also helps you understand how it can be caused by bad stuff in the lungs and bad stuff outside the lungs. So definitions wise, this is quite important because some of the papers that we'll look at when we look at the evidence behind what we do to manage these patients is older than 2013. So sort of pre-2013, we would define ARDS as an acute injury of the suggestive etiology, severe hypoxemia, and we look at PF ratio, which is the ratio of the the arterial oxygenation divided by the fraction of inspired oxygenation. And that's how you sort of you compare two different patients, one's on 30% oxygen and one's on 100% oxygen from the ventilator. If they've got the same PaO2, then the one who's on 100% is obviously sicker than the one who hasn't. Absence of cardiac failure, so they describe it with a capillary wedge pressure of less than 18 millimeters of mercury and CVP that's low, and then diffuse bilateral infiltrates on chest X-ray. And actually then, this was sort of defined at a time that we used loads of pulmonary artery catheters, and now we really use very few. We might use the odd one or two in Glenfield, but we certainly don't use it routinely for our ARDS patients. We would generally use it for people with bad hearts. So in 2013, a load of people sat down, presumably in Berlin, which is why it's called the Berlin definition, and they sort of updated ARDS. And they divide it into timing, so it's got to be within a week of a known insult, and we'll talk about those known insults in a minute. Chest imaging, they realised that actually you can have both ARDS and heart failure at the same time. So and also sometimes a chest X-ray can look relatively normal, and then you trot them through the CT scanner and realise it's really not normal at all. So you had bilateral opacities that weren't completely explained by heart failure, and that could be seen either on chest X-ray or on the CT. The origin of the edema was not fully explained by heart failure, again, so ARDS could occur in people who also had heart failure. And they divided it into mild, moderate and severe by the different PF categories. And although we use kilopascals, everyone else in the world pretty much uses millimetres of mercury, and the numbers actually are much easier with millimetres of mercury. So we define mild ARDS as having a PF ratio of greater than 200, moderate 100 to 200, and severe is less than 100. And just worth remembering that when we're looking at older papers, so pre this 2013 definition, they actually they call what we now call mild ARDS as an acute lung injury. So that's just important when we're looking at some of the data. So that is something that you would be expected to trot out in an exam. So what causes it? So we've already sort of mentioned this, there are bad things in your lungs that can cause it, and there are also bad things outside of your lungs that can cause it. And this is taken from the sort of 2001 paper, which we'll talk about in a little bit about lung protective ventilation. So this shows us that actually about a third of the patients we're looking after have got pneumonia, so bacterial, viral, bit of fungal, and about a quarter of severe sepsis somewhere else. About 15% are an aspiration pneumonitis, then about 1 in 10 are trauma, and then the others are lots of different things that we've seen, including things like pancreatitis. So you can actually divide ARDS into pulmonary causes, so bad stuff in your lung, and extrapulmonary causes, so bad stuff outside of your lung. And I think that's really important to remember when we're thinking about going on to kind of managing it, because actually the pathophysiology is probably a bit different if you have ARDS secondary to pancreatitis to ARDS secondary to pneumococcal pneumonia, but we do tend to lump it all in together when we're looking at the papers. So what actually happens? So we'll talk at the sort of what happens at the cellular level in a second, but basically it's divided into 3 stages. And you've got your acute exudative stage, and that happens sort of a couple of days after the original insult, whether that's a pneumococcal pneumonia or pancreatitis, and goes on for that first week. Then you go into sort of fibroproliferative stage, and this happens somewhere between 1 week post-insult and 3 weeks post-insult. Sadly, you can die at any stage of ARDS, but usually that's not due to severe hypoxia. That's usually due to multi-organ failure, which may be as a consequence of severe hypoxia because you're just not getting enough oxygen to your organs to keep them alive. That fibroproliferative stage is really important because actually that's when lungs are really brittle. That's when things like pneumothoraces occur. That's when you can get secondary infections, and of course a secondary infection like a ventilator-associated pneumonia will adversely affect your patients. It's like a second hit on already damaged lungs. And then after, if you can survive the fibroproliferative stage, then lungs have a variable ability to heal. And actually, I mean, they're not quite as good as your liver. So your liver's got amazing regenerative process properties, but your lungs have, your lungs have less of a regenerative properties, but they can recover, and sometimes that recovery can take 6 months, 12 months, or even sort of 2 years or longer. And really, what affects what your final outcome is how much of your lungs recover to sort of normal, and how much of your lungs repair themselves by fibrosis, causing scarring. So hopefully this will bring back some memories from medical school days, and hopefully all of our alveoli capillary at the moment look nice and happy like this. I think you'll remember that we divide it into type 1 cells. This accounts for about 97% of our alveolar surface, and they provide nice thin barrier for oxygen and carbon dioxide to diffuse across. You then got your type 2 cells. Type 2 pneumocytes are the little dudes that chuck out surfactant, which is the reason why our tiny little alveoli don't collapse, because they decrease the surface tension. You've got these guys who are your alveolar macrophages that chock around in your alveoli and are kind of like your sentry duty white blood cells. So they sort of mop up stuff that shouldn't be there, like pathogens. And then you've got a really nice narrow gap between, I don't know if you can see my arrow, between your alveolus and your single-celled capillary in your lungs. And you can see that it's very easy for oxygen to diffuse out of the alveoli into the capillaries and for CO2 to go the other way. So that's hopefully what all of our alveoli look like at the moment. What happens in ARDS? So this is an unhappy ARDS alveolus. And the first thing that happens is you get that either direct injury, so that would be an aspiration or a bacterial pneumonia, or an indirect injury such as pancreatitis or severe sepsis, and that causes those alveolar macrophages, those little sentry duty white blood cells, to release lots of pro-inflammatory cytokines. And forgive me, this is a very simplified version of what happens, but it's basically how my brain works. Once these cytokines, what these cytokines do is they attract neutrophils, which you wouldn't normally find in your alveolus, to the alveolus and to the interstitium, which is the bit in between your alveolus and the capillary, and they start to break down the alveolar capillary membrane. And basically they break down those type 1 cells and they replace it by something called hyalin. And actually, some of you will remember that neonatal respiratory distress syndrome, which happens to the preemie babies who are born before they've got sufficient surfactant, is also called hyaline membrane disease. And that's because these thin type 1 cells are replaced by this hyaline membrane. And already you can see that actually that's much thicker, that's much harder for oxygen to diffuse out and CO2 to diffuse back in again. The next thing that happens is you get a breakdown of that alveolar capillary membrane integrity, and you get this kind of flooding of both the alveolus and the interstitial space with this protein-rich edema. So that just increases the distance that your oxygen and CO2 have to diffuse across to get in and out of your alveoli into your blood. And the type 2 cells don't actually die, but they stop producing surfactant, or they produce surfactant that isn't as good. So some of those alveoli get flooded with this proteinaceous fluid and they collapse in on themselves, and also they're more likely to collapse because you haven't got that surfactant, which is sort of decreasing the surface tension. So that's kind of the bad stuff that happens during ARDS. And then that happens in that first sort of 4 to 7 days, so in that acute inflammatory bit. And then in the 1 week to 3 week bit, where I've already said that the lungs are quite brittle and are at risk of sort of secondary infections and things like air leaks, so pneumothoraces, really how well your body is going to cope with this, how well your lungs are going to repair, depends on how many of your type 2 pneumocytes can start differentiating back into type 1. So you've got that nice thin capillary membrane that you can see on the left-hand side of this picture. And then how many of them actually fibroblasts cause collagen deposition, and that causes fibrosis. So that causes that sort of honeycombing and that scarring that we can see. So that's what's happening at the cellular level. So what do we actually do about it? So if you really wanted to go off to sleep for the next half an hour, please feel free to do so, because this is basically what I'm going to do, a bit of a romp through the literature. So this is what I do. So it's not rocket science. Treat the underlying cause, give them antibiotics for their pneumonia. Aim for levels of PaO2 and PaCO2 that are compatible with life. We could probably argue all day about what is compatible with life, but essentially a PaO2 of probably 7, 8 and above, most of us are happy with, which is SATs of about 88 and above. And PaCO2, again, I'm not that bothered about your PaCO2 if you are well compensated for it. So I think actually pH is more important. And generally, again, in these patients, because we're trying to minimise further damage, we won't try and normalise CO2. I think what ICU has taught us, all the ICU research has taught us in the last couple of decades, is that we shouldn't aim for normality, and our bodies have got quite a lot of tolerance through millions of years of evolution. But a pH probably at 7.2 and above, especially if they've got a normal RV. We then want to do good ICU and basically minimise any further harms. We want to avoid Valley and Villi, which are ventilator-associated and ventilator-initiated lung injury. We know that ventilation can be bad for your lungs, especially if they are brittle, they're in that fibroproliferative stage. We want to avoid further infections, which again is just good ICU care, and we want to get them moving, rehabbed as soon as possible. We're then going to pick lung protective ventilation, a strategy with sensible amounts of PEEP, and I'll talk about what I think is a sensible amount of PEEP in a bit. We're going to prone them. Proning works. It's great. We're going to turn them on their front. Everyone's very happy with proning, or very familiar with proning maybe after COVID-19. We're going to keep them crispy dry. We sacrifice kidneys sometimes for lungs. Kidneys are far more forgiving and usually will come back once the patient's got a bit better, but lungs are far less forgiving. We'll think about paralysis. Again, the jury's out a little bit on that. We'll maybe think about steroids, and I'll explain where the controversies there lie. We might think about APRV, the Marmite of ventilatory techniques, in selected cases. And then finally, if all of that is failing, you could pick up the phone or get on the computer and refer a patient and refer for consideration of ECMO. So first things first, lung protective ventilation. So this is now a paper that is more than 2 decades old, which makes me feel pretty old. But essentially what they were doing, at the time, people used to ventilate people with big tidal volumes but low amounts of PEEP, which to us now seems ridiculous because hopefully this should now be a standard of care. So in this paper, they actually weren't looking at tidal volumes, they were actually looking at pressures, and they were comparing a pressure of a plateau less than 30 to a plateau of less than 50. And actually that sort of corresponded to a tidal volume of about 6 mils per kilo of ideal body weight. Ideal body weight is really important. If any of you, and I'm sure you all have trotted a bigger patient through a CT scanner, you'll realise that actually all the organs are related to the patient's height rather than to their weight. And actually, even if you are 150 kilos, if you are 5 foot, your lungs are the size of a 5 foot patient's should be. So you always want to normalise it to ideal body weight, not actual body weight. And this was a big multi-centre randomised controlled trial, almost 1,000 patients, and actually it stopped early because they showed a significant reduction in mortality if you ventilated with 6 mils per kilo of ideal body weight, tidal volume, and you kept your plateau pressures less than 35. And that was comparing to ones with much higher tidal volumes and plateau pressure of less than 50. I think what's quite important here is to realise how heterogeneous ARDS is. I think before we could CT scan these people, we used to do a chest x-ray, and it can actually just look all a bit white on a chest x-ray. It can look quite homogeneous. And then we started trotting people through the scanner. And this is actually not on lung windows, this is on liver windows, but it's to kind of illustrate my point. So the reason why we're aiming for small tidal volumes is if you trot a patient through the scanner, this is a patient who's lying on their back, and you can see that the lungs are definitely look different in the different areas, and that's to do with which bit's dependent. So this anterior bit, black's good because black's full of air on this scan, so this is the nice normal bit of lung. Right at the back of the lung, so posterior, because this patient's lying on their back and gravity is working here, we've got loads of alveoli that are flooded with protein-rich fluid that are totally collapsed. No amount of pressure is going to open them up. And then in the middle, we've got some alveoli that are collapsed, some alveoli that are flooded, but actually with a little bit more pressure and a little bit more PEEP, we might be able to open them up and keep them open so they can participate in gas exchange. So really what we're doing by minimising tidal volumes, minimising to about 6 mils per kilo of ideal body weight, we're trying to protect this normal bit of anterior lung, which you can see is only about a third of this patient's total lung capacity. Interestingly, if you look at CT scans of ARDS survivors a year or two down the line, actually the worst bit of fibrosis is often in this normal anterior bit of lung. So actually that's not damage from the disease, that is damage from what we've done to try and get them through the disease, so damage from the sort of ventilation. So that's why it's really important to understand why we use these small tidal volumes. So there's been a couple more big trials. The second Ards study basically showed the same. It's about 550 patients, and there was another study done in multiple European ICUs in 2005, which basically showed the same thing. So my question is, do we actually do it? If you went onto your unit now, I bet if you looked at tidal volume, there would be patients that would be ventilating at over 6 mils per kilo of ideal body weight. The next thing is, should it even be lower? And actually, there was a trial a little while ago looking at 3 mils per kilo of ideal body weight and using a sort of extracorporeal CO2 machine to clear the CO2. But actually, that didn't show. The cynic in me thinks that was because the people who made the machines were trying to sell the machines, but actually the rest of the trial didn't show that necessarily much lower tidal volumes is what we should be aiming for. Is this important for people with normal lungs, this ideal body weight tidal volume of 6 mils per kilo? Well, it probably is. So this paper that I've got here is the trial of intraoperative low tidal volume ventilation abdominal surgery. It's a French trial. Loads of the ARDS trials are in France. It's probably quite a good place to have your ARDS if you're going to get it. And they looked at about a significant number of patients who were having abdominal surgery, either laparotomies or laparoscopies, so reasonable size surgery. And they divided them into 2 groups. They divided them into one group who had lung protective ventilation, so sensible amounts of PEEP, 6 mils per kilo of ideal body weight. And the other group were just ventilated, however the anaesthetist wanted to ventilate them in theatre, which, as it turned out in this paper, was at times quite crazy. So some of them were really fat people with really low amounts of PEEP, or people with much higher tidal volumes, and I think we would normally dial up. And it wasn't powered for mortality because these are well patients coming in from home, having abdominal surgery, but they looked at the outcomes of post-op chest infections, the post-op need for non-invasive or invasive ventilation, hospital and ICU length of stay, and they found that all of those were higher in the group that weren't lung protectively ventilated. So actually, we should be doing this even for people who are going to be ventilated for a short amount of time for an operation who have essentially normal lungs. So the open lung approach, now I sort of mentioned this a little bit already when I showed you my CT scan of the ARDS patient, because what I'm actually talking about is that middle bit of lung. So those are alveoli that are flooded with proteinaceous fluid, all those kind of nasty inflammatory cytokines, and some of them are collapsed. And actually, the open lung effect, approach is trying to use a bit more pressure to open up those sticky alveoli and then a bit more PEEP to keep them open. So actually you're recruiting more of the lung to participate in gas exchange. And what you don't want to do, because another way that you can damage alveoli, but you can either use too high pressure or too high volume, or they really don't like opening and closing cyclically. So that kind of produces what we call atelector trauma or biotrauma, because actually if you cause them to open and close with every breath that you're giving them on the ventilator, they chuck out more inflammatory cytokines, which is the problem in the first place. You're just perpetuating the problem. There are some problems with this open lung approach. So this is using higher pressures and then higher PEEP in various different ways. It can affect your CO2 clearance. Your RV can not like it, especially if you've got a failing RV. You can cause barotrauma. You can increase intracranial pressure or decrease cardiac output. Quite a lot of us have got a right to left shunt. So quite a lot of us have got a PSO, about 1 in 5, which is generally closed, but then might be opened if we have high right-sided pressures. So you could increase your right to left shunt by using higher pressures. You certainly can worsen air leaks, so people who've got pneumothoraces or pneumomediastinum. And if you're using really high PEEP, you can actually drop their splanchnic blood flow, so you can affect the blood flow to the other organs. So PEEP, we know that if you're sick, you need a bit more of it, but how much is the right amount of PEEP to use in your ARDS patient? Well, this was 2008 was obviously PEEP year, and these were the sort of two seminal papers. Neither of them could actually show an improvement in mortality with higher PEEP, but they both showed, and they had a slightly different way of calculating PEEP, but essentially in both trials, one of which was about 900 patients, the other one which was about 700 patients. They're big ICU trials. They essentially had low PEEP was somewhere between 5 and 8, and high PEEP was somewhere between 10 and 14 for most of them. So that's sort of the two groups that they found. So no difference in mortality, but they did find that if you were sicker and you had higher PEEP, then you got off the ventilator more quickly and you got out of ICU more quickly. So they had shorter ICU length of stay. They then published a couple of years later a meta-analysis. And I think this is a little bit cheeky because this is basically just those PEEP papers plus one others. And I'm not sure whether 3 papers makes a really good meta-analysis. But essentially, and this goes back to our definitions where we talked about acute lung injury being what they used to call, what we now call mild ARDS. And this meta-analysis essentially says if you just take the ones with severe or moderate ARDS, that's a PF ratio of 200 or less, then actually you can show a mortality benefit with using a higher amount of PEEP. So probably sicker lungs need higher PEEP, and that makes sense, doesn't it? Because you're trying to open up that sticky bit of the middle part of your lungs and trying to keep those alveoli open so they can participate in gas exchange. Now, what is ideal PEEP? Lots of clever people will tell you they know the best method for calculating ideal PEEP in their practice. There's lots of different things you can look at. You can look at the pressure volume loops. You can look at the upper or lower inflection point. You can do a stepwise recruitment maneuver. You can look and see where you get the best static compliance. You can stick down an esophageal pressure and use that as a surrogate for pleural pressure and see where you can get, again, the best compliance. Or you can do what they did in the Ards trial, which was our first lung protective ventilation trial. And actually they said, if you need more oxygenation from the ventilator, you have thicker lungs, you will need more PEEP, and you just go up stepwise. Although I don't think that many people in the UK use PEEP of 18 to 24. And in fact, that's something that I have never done in my practice. I've never gone much above sort of 15, really even in the very large patients, but they do use higher PEEP in Europe. Essentially, there is no good evidence that tells us which is the best way to calculate PEEP. Personally, if I'm ventilating somebody for airway protection or, say, for example, they've taken an overdose, they're neurologically obtunded, and they are normal size, I might start with a PEEP of 5, and if they're big, I might start with a PEEP of 8. And if I'm intubating somebody for hypoxia, because they've got ARDS, for example, I'll probably start about 10 and then titrate up to 15. I might start at 12 in the really big patients. Recruitment manoeuvres. So again, this is sort of the open approach. So that's taking that sticky middle bit of lung where some of those alveoli are potentially recruitable and using a higher pressure to open up those alveoli and then keeping a higher level of PEEP to keep them open. Now, I never particularly liked lung recruitment manoeuvres, and I think that was because the patient population that we look after with ECMO have got the severe ARDS, so they're probably even more brittle than, your average ARDS sort of patient population. And it just seemed to be a really bad idea with people with brittle lungs to suddenly give them like a big breath to try and recruit that middle bit of lungs. And generally what people would say is you give 40 centimetres of water for 40 seconds as a recruitment manoeuvre. And that always just seemed a bit much when we're busy trying to, minimise our plateau pressures to protect our lungs and using as part of our lung protective ventilation strategy. So I was quite pleased when this trial actually came out in 2017. And this is quite an impressive trial. It's 1,000 patients. It's multi-centre. It was done in South American and European centres. So it's sort of global multi-centre. And they essentially had two groups. So one of them, they titrated PEEP as per that Ards net, as per this table that I've just shared with you. And in the other group, they put them through a thing where they went to 25 centimetres of PEEP for a minute, 35 centimetres of PEEP for a minute, and then 45 for 2 minutes. Now, halfway through the trial, they had to stop that and they minimised the pressures a bit more because 3 patients in the arm having the recruitment manoeuvres had suffered cardiac arrest. All 3 had been resuscitated from their cardiac arrest, but they thought maybe we ought to minimise that a little bit more. And actually in the second half of recruitment, they only went to 35 and they spent less time at 35 centimetres of water. And they actually showed that mortality at 30 days and 90 days was higher in the recruitment arm. So for me, that takes out recruitment as something that we should be trying. And these patients had moderate to severe ARDS, so a PF ratio of less than 200. What about APRV, the Marmite of ventilatory modes? I'm sure probably you've all had experience with using it during COVID, but essentially what it does is it provides a high level of CPAP throughout the respiratory cycle that the patients can breathe on top of. And then throughout that cycle, you get short cyclic releases, which help CO2 clearance. And it's something that I use quite a lot, and I use it in patients who are bigger. So obese patients, I use it as a method to recruit my patients, and I use it in those that you're unable to crone. Is there any evidence for it? Well, APRV is one of these things that for ages improved your numbers, so it improved oxygenation, but actually no one showed any patient-centred or mortality benefit. And we still don't have good quality evidence that it improves mortality, and there are questions around whether APRV provides you with lung protective ventilation, because sometimes the ventilator is really measuring much higher tidal volumes than that 6 mils per kilo that we already know can improve mortality in ARDS. But this is probably the only study that's got patient-centred outcomes reported better with APRV than conventional ventilation. And it's not a big study, just shy of 140 patients, single centre in China. And they divided them into normal ARDS net so 6 mils per kilo, and PEEP as titrated by the oxygenation that they need from the ventilator that we've already talked about, versus APRV. And they actually couldn't show a significant mortality benefit, doesn't quite reach significance, but they did show that if you had APRV, you were less likely to need a trachea, you were more likely to be successfully extubated, and you spent significantly less time on the ventilator. So we do have some evidence from at least this single centre study, that it may improve patient-centred outcomes. Fluid management. So it kind of makes a lot of sense. If we think back to that poor little injured alveoli, like a lot of the problems are this proteinaceous rich fluid that is flooding the alveoli, that is increasing that distance between the alveolus and the capillary. So it kind of makes sense that actually if we try and dry these patients out to get rid of some of that extravascular lung water and some of that water in the alveoli, that it will improve their oxygenation. And certainly after the resolution of shock, because especially if you've got a patient with septic shock, they may well need fluid loading right at the beginning. We tend to use furosemide. You can use it as a bolus or an infusion. We quite often use an infusion because we think it's gentler, but there isn't any really good evidence for that. And we also add in spironolactone because a lot of patients get hypernatremic, and I think that this is really a form of torture that we do to our patients to render them hypernatremic, because if you've got high sodium in your blood, your hypothalamus will be screaming that you are thirsty, and then of course these patients can't drink because they are intubated. So we'll add in spironolactone to try and manage that hypernatremia, that high sodium they get. And we'll actually have quite a low threshold to use renal replacement therapy to actually remove that water. But is this evidence-based? And the answer is actually yes. So this is the FACT trial. This was 2006. Again, it's a really big study. It's 1,000 patients done in ICU. And actually what they were doing was comparing two different things. They were comparing a liberal fluid strategy with a conservative fluid strategy. And they were also comparing use of the CVP versus the pulmonary capillary, the pulmonary artery catheter. But if we just look at the fluid stuff, they had good separation between the groups. So within that first week, the fluid liberal group were 7 litres positive, and the fluid restrictive group were essentially even. They again couldn't show a difference in mortality, but they did show improved lung function scores. You got off the ventilator more quickly, and you got out of intensive care more quickly. So good patient-centred outcomes. And what they didn't show, because obviously what we worry about, isn't it, when we're drawing patients out quite aggressively, is will that affect their kidneys? Will that mean that we have to use much higher cardiovascular support, much more vasopressors? But actually they didn't see increased risk of shock or need for dialysis, which they described as non-pulmonary organ failure. There is a little caveat actually to this paper. This was a post hoc analysis of a small number. I think it was so it's 1,000 patients. So of the survivors, they followed up at just over 100, and they did telephone interview to look at neurocognitive and psychological factors in the survivors. And they found that if you had significant hypoxia during your ARDS time, that actually you had a higher degree of neuropsychological problems, so cognitive problems and psychological problems, which isn't really surprising. But they also showed that in the fluid restrictive group, there was a trend towards higher neurocognitive problems as well in this. I mean, arguably, I guess, in order to have neurocognitive problems, you have to have survived your ARDS in the first place. And I don't think this would make me change my practice yet. And I haven't seen any more data sort of suggesting this, but it is something to watch out for. And certainly that's something I'm keeping an eye on. Proning. I love proning. Proning works. So proning is really one of the only things that we do, apart from lung protective ventilation in ARDS, that improves mortality. And again, a bit like APRV, initially all the data that we had showed that it improved oxygenation, but it didn't actually improve mortality, and it was small studies. And then this, which is another French trial, 2013, that it was published, and they proned their patients for much longer actually than proning had been done before, so 16 hours. And they found that for patients proned, there was a significant improvement in mortality. So at 28 days, so a month down the line, only 16% had died in the prone group, and 33% had died in the patients who weren't proned. And again, they were using severe ARDS and the severe half of moderates. They used a PF ratio cutoff of 150, and that mortality benefit carried on to 90 days. So it does work, and it does improve mortality, and it is worth doing in the patients that you can do it in. Why does proning work? Well, if I take the CT scan that I showed you earlier when we were talking about why we use small tidal volumes, and we'll talk about the open lung approach to kind of open up the sticky middle bit of those lungs, you can see that if I literally turn that picture upside down, suddenly you've got better blood flow to the normal little baby lung that is nice and black on this picture and full of air. So you get an improvement in your VQ mismatching. You also get quite a lot of, so your heart and your mediastinum in your chest actually squishes, particularly your left lower lobe when you are lying on your back, and you get quite a lot of atelectasis behind your heart, especially of your left lower lobe. If you turn them on your front, you can open up the left lower lobe, so you can recruit that bit of lung. And again, especially in the bigger patients, I know they're a pain to turn and we have to think about our backs, but actually proning is even more effective often in obese patients than it is in thin patients. And that's probably because we improve their thoracoabdominal compliance. So the bigger you are, the heavier your chest wall is when you're lying on your back. If you put them on the front and you get the pillows in the right place, you've actually got your belly and your chest wall sort of hanging free. It does facilitate secretion drainage. Anyone who's been at the head end, who's turned a patient, who's got it all up their arms, will agree with me. And actually, it's a good way of recruitment for various different reasons, including the fact that actually your left lower lobe particularly is squished behind your cardiac weight. And what we often find is that actually that proning, that improvement in oxygenation in prone position persists even once we've turned the patient back supine. So proning works. Definitely prone your patients if you can. Why might we not? Well, these are all the sort of worrying things. Personally, I find really sick babies absolutely terrifying, and the only time that I am jealous of my paediatric colleagues is when I watch them prone a baby and they just with one hand turn them over, and then I turn back to my 140 kilo ARDS patient that we're having to prone with 7 of us. So there are some bad stuff about proning. All of your lines can fall out when you're actually proning. It can increase your intracranial pressure. It's quite difficult to do stuff when they're on the front, like put in lines, reintubate, do chest compressions, although you can. Sometimes they don't feed so well. Sometimes the monitoring's a bit weird because things are in a weird place. Although it is free, you do need at least 5 staff to turn a patient safely, really, and maybe 7 if they're big. It can squish your liver just a bit and decrease your intra-abdominal perfusion because of increasing intra-abdominal pressure. And certainly if you turn a patient prone and their lactate climbs quite significantly over the next few hours, I would turn them back supine because I'd be worried about the effect on the liver. You can get them quite puffy and you can get pressure trauma in all sorts of areas. Most of these risks can be mitigated by careful pressure control and things like that when they're on their front. Who do I prone? Even I would balk at proning him, to be honest. But basically, anyone who needs more than 60% to get a PO2 of 8. There are people you can't prone, so if they've got unstable C-spines or open chest or abdomens. And then there are relative contraindications. So if they've got severe eye, face, head injury, if they've got spinal injuries, if they've had a recent abdominal or chest surgery, or if they are, if they're very round the middle because they have got ascites or they're in sort of later stages of pregnancy, or they are super morbidly obese. And I think very carefully about people who are quite unstable cardiovascularly. So if they're on lots of different inotropes or vasopressors, if they've got a balloon pump in, and then if they're bronchospastic, because actually just turning them on their front will move their ET tubes up and down in their trachea, and that can sort of perpetuate the wheeze and make the wheeze worse. How about paralysis? So paralysis is something that's also been tried in ARDS. The aim is to improve patient ventilator synchrony, which isn't surprising if they can't fight the vent. But we do worry about paralysis because we know that it can increase critical illness weakness, which can mean that they're on the vent for longer, they're in ICU for longer, and they have a higher mortality. It may reduce the patient's own effort. If you've seen a patient breathing spontaneously in the early stages of ARDS, they can look like they're drowning. You know, they're often generating really high pressures and they're breathing really quickly. And so actually going off to sleep, sedating and paralysing them may reduce that drive. Two big paralysis trials. The first one is the French study, which was published in 2010. Not that big, 340 patients in about 20 different French ICUs. Again, severe ARDS and the moderate bit and the severe bit of moderate ARDS. And they gave them a 48-hour infusion of cisatracurium, and they showed in that group that improved survival, and these patients got off the vent more quickly, but they didn't see more neuromuscular weakness. But actually, there's been a more recent trial called the ROSE trial, which is from the States, and it's much bigger. So it's 1,000 patients in 48 different ICUs. And that trial actually didn't find any difference in mortality, but they did find a higher adverse event in the paralysed arm, more cardiovascular. So actually, essentially, in the paralysed arm, more of them needed vasopressor support. So the jury's out a little bit on paralysis, but it's certainly something that I would consider, especially in a patient that wasn't sinking with the vent early on. What about steroids? This is also incredibly controversial. So again, going back to our poor little injured alveoli, a lot of the problem here is inflammation. It's those cytokines, it's the neutrophils being attracted, it's that the cytokines sort of perpetuating this inflammation. So it sort of makes sense to give something that dampens down the inflammation, such as steroids. But the trials are a bit borderline here. So the first trial, Majuri, he's the steroid man. So he brought out his first trial, and this is 98. So this is even before we're doing lung protective ventilation. And it was quite miraculous. He basically only had 24 patients in it, originally powered for 100. But they had a massive improvement in mortality in those that received steroids. And he was using 2 milligrams per kilogram of methylpred, so a reasonable dose. However, the ArdsNet people who published their second ArdsNet papers in 2006, which we talked about a bit earlier with the lung protective ventilation, they actually said that if you didn't start, that they didn't find any difference in mortality in a post hoc analysis of which patients got steroids and which didn't. There was no difference in mortality, but actually, if you started steroids more than 2 weeks post the beginning of your ARDS, more of those patients died. And they were also worried about the fact that in the steroid arm, more patients got reintubated, which is probably because more of them had neuromuscular weakness associated with steroids. So they said, no, really not sure about steroids. So Majuri came back the next year and went, no, I was right all along. And he used it earlier. So it had to start within 72 hours. He used half a dose, so 1 milligram per kilogram of methylpred. And again, he showed a significant improvement in mortality, in lung injury scores, and the amount of time these people spent on the ventilator if they were given steroids. But again, it's quite a small study, and the groups weren't that well matched. So the group who didn't get steroids had a much higher rate of septic shock, and we know that we use hydrocortisone in vasopressor-resistant septic shock, and that might have given us the reason for the mortality difference. So do we use steroids? Yes, we do. We tend to use them in non-resolving ARDS after about a week, but hopefully starting before that 2 week. There has been a meta-analysis published a bit more recently on this. So this was published in 2016. But if you look at the lead author, who is Majuri, you can see that maybe it's not the most balanced view. So I think that steroids are something that is useful to think about, but in non-resolving ARDS, I wouldn't go in straight away with steroids. Obviously, we're not actually talking about COVID here because we know that dexamethasone is associated with improved. So what about lots of other things that have been tried? And the poor little mouse, volunteer mouse in that picture, is breathing underwater because he's in a beaker of perfluorocarbons, liquid ventilation for the future. So lots of things have been tried that actually have either shown no improvement in mortality or actually have shown to be harmed. So high frequency oscillation, pulmonary vasodilators, they make your numbers better, they don't improve long-term mortality, they might buy you a bit of time. Beta-2 agonists, so salbutamol, turns out if you give that either nebulized or IV to ARDS patients, they just get tachycardic and they don't have improvement in their lung parameters and their gas exchange. Surfactant, so we talked about how hyaline membranes are forming in the alveoli and how in the neonates we give them surfactant when they are born prematurely to prevent neonatal respiratory distress syndrome. So we went through a phase of using calf surfactant, so calfactant, which involved syringing 50 mils of this stuff down people's ET tubes, which kind of felt a bit wrong for your severe ARDS patient, and actually, as it turned out, didn't make any difference to them, so it was probably not very helpful. And there's lots of other things that have been used, and there's some really interesting sort of research at the moment looking at things like stem cell therapy. Well, all of this is a bit watch this space. So in summary, I hope you haven't all gone off to sleep. So ARDS, treat the underlying cause, don't aim for stuff, aim for PO2 and CO2 that's compatible with life, don't aim to normalise it, minimise further damage, use lung protective ventilation, sensible amount of PEEP, dry them out, consider APRV, especially if you think they might be recruitable, prone, keep proning if it's working, think about paralysis, maybe consider steroids, and then if all that's failing, then think about referral to us in ECMO. And that's it. I will stop sharing my screen and I'd be happy to take any questions.
Thanks, Kaz, that was great. Any questions?
I hope you knew that already, Matt.
Well, I'll learn a few things.
I just asked about this. She was mentioning that the late steroids is causing problem. What does it take here? Like in your practice, when do you start?
I don't know if you caught that, Kaz.
I can't, sorry. No.
So,
say again?
Noel, one of our registrars, was just asking in our practice, when do we tend to start steroids? Is there sort of a time frame about when we would do it?
So we try and get them in that window between ARDS that isn't going to get better with steroids and ARDS that isn't now 2 weeks down the line where we may increase mortality by using it. And so we often think about starting them at day sort of 12, 13. Now, I think, thinking about the ECMO population, I have seen some people who it felt like they got better literally on the end of a syringe giving them steroids. Do I think that that means that steroids works? No, I think that probably means that we've got a steroid responsive condition underlying that we just haven't diagnosed yet. So we have had a few, probably of acute interstitial pneumonitis, so inflammatory lung diseases, that have got better with steroids. But I think the jury's out a little bit on whether steroids works in all comer ARDS. And again, it goes back to that sort of difficulty of non-pulmonary is probably quite different to pulmonary ARDS, but we lump it all together. I think we have a bit of a mantra that no one should die without at least a trial of steroids. But whether we are improving outcomes with them, that's why I wouldn't jump in early with them, if that answers your question now.
He's nodding.
Like the reason I asked it, Matt, because in COVID, like once the like nearly like 10 days or 14 days of incubation, then once we do more fibrotic, then we say like, can we do some strong dose of steroids, like 1 gram for the next 3-4 days, and then see possibly that works certain situations. But I've seen certain hospitals using median time in the normal ARDS, not COVID, non-COVID ARDS, from 7 to 10 days somewhere. In 1 week it starts working. Is there anything in your practice? Anything?
Again, Kaz, I don't know how much of that you could catch, but
I know. I think I got that. It was. Is there any new evidence to show that works? Was that the question?
Basically, yeah.
Yeah. No. Not as far as I know. The only thing we've got is that meta-analysis, but like I say, that is authored by the jury. So it's kind of like the steroids are great and we should use steroids in everyone. I think COVID was, I worry that our pendulum with steroids may now have swung a bit too far the other way because it was used in COVID, because actually we did get loads of secondary ventilation associated pneumonias in the COVID patients. And I wonder if the higher dose steroids sort of made that worse, but also was it just that they were on the ventilator for a lot longer? So, your risk increases every day you're on the ventilator. I think it's something that's worth trying in your ARDS patients. We slightly randomly with the ECMO patients, and there is very little science to this, to be honest, is that if they are sick and in multi-organ failure or a bit older or a bit frailer, we tend to use the Majuri dose, so we'll use 1 to 2 milligrams per kilogram. And if they are a bit younger and fitter, and especially in single organ failure, we'll tend to use a pulse of a higher dose of methylpred. But again, there is no evidence behind that. It's just something that we felt seemed sensible.
Cool. Thumbs up from Noel. Any questions for anyone else? Tanmay, anyone at the Royal?
I have a question. So how does the ventilatory strategies in ARDS is different from a patient who is on ECMO? So just like, do we still target the same, like preventing all the traumas, or how do we target the aim of ventilation with the patient on ECMO already?
With ECMO patients, what the ECMO machine allows us to be is much more gentle with the ventilator. So with the ECMO patients, we will classically have them on what we call rest settings. So that will be basically 20/10. So PEEP of 10, and then either a peak pressure on BiPAP of 20, or if they're spontaneously breathing, we'll use just 10 centimetres water ASB, because the ECMO machine will clear the CO2 and do some of the oxygenation for us. So we can be even more gentle with their fragile lungs to try and prevent further damage. But if you turned most of your non-ECMO patients with severe ARDS down to those low pressures, you're probably not going to get adequate CO2 clearance.
Yeah.
You've always got to aim for it, but it's sometimes not. It's a balance between getting that pH of 7.2 and above and minimising the pressures and the driving pressure.
Okay, thank you.
Okay.
Any other questions? We haven't got a journal club today, unfortunately. It's been a bit of a miscommunication, but we'll rearrange that for another date. So if we don't have any other questions, thank you very much, Kaz.